Okay, so welcome to Eat, Move, Think, the show about optimal wellness brought to you by Medcan.
Wow. Do it again.
Oh, I was practicing. Okay, ready?
Welcome
to Eat, Move, Think,
the show about
optimal
wellness brought to you by Medcan.
Yeah, this is extremely good. Thank you.
Okay, Chris, let's play a game.
I'm game for a game.
I'm going to rally off some foods, and I want you to tell me whether or not those are high in FODMAPs or not.
This is presupposing that I actually know what a FODMAP is, but let's shoot.
Apples.
Not high in FODMAPs, I would say.
That was wrong. Apples are high in FODMAPs. Garlic.
High in FODMAPs.
Yes, very good.
Okay, interesting.
Quinoa.
Low in FODMAPs.
Okay, yes, very good. I would say you're doing very well. And let's end it off. Let's do wheat.
Wheat. Low in FODMAPs.
Oh, that one is high in FODMAPs. That's the number one on this list, actually.
So can I just, what is a FODMAP?
Yeah, it's
what
fair
is
to ask.
What is a FODMAP?
So a FODMAP, well, that's an acronym, but FODMAPs are a group of fermentable carbohydrates. And so you classify foods as either high or low. In this
episode, at some point, do we say what FODMAP stands for?
Someone much more qualified than myself breaks it down in easy to understand fashion, and she rallies off what the acronym is and then also breaks down like what they do to your gut.
Okay, and why do I care about FODMAPs?
If you've ever experienced gastrointestinal issues, or if you've been diagnosed with irritable bowel syndrome, learning about which foods are high or low in FODMAPs could drastically change the way you live your life. I'm Jasmine Ratch.
I'm Chris Scholgen.
We're the producers of Eat, Move, Think. So this episode is all about how you can treat IBS with the low FODMAP diet.
I assume our eat expert, Leslie Beck, is the one hosting this episode?
Absolutely, yes, she is. She's chatting with Kate Scarlata, who's another registered dietitian. She's based in Boston, and she's also an international expert in IBS and FODMAPs and the low FODMAP diet. She also has a new book out. It's called Mind Your Gut, the science-based whole body guide to living well with IBS.
This episode sounds like it's going to be a really great resource.
It is, and it's not just what you can eat to treat your IBS, it's other things in your life that you can do. So there's lots of different ideas and tips in here. And it's also a great understanding. You know, sometimes these are embarrassing questions to ask, so you don't even have to ask them. We're answering them all already.
Amazing. All right, well, let's get to it.
Let's throw it to Leslie Beck.
Hi, everyone. Welcome back to Eat, Move, Think. I'm Leslie Beck, and I'm excited to be here today with Kate Scarlata. Kate, how's your day going so far?
It's going fantastic.
Yeah, and you're in Boston right now?
I am in Boston. I spend my summers in Maine, which I can't wait to get back to. But in the winter, I'm here outside of Boston in the suburb of Medway. It's a little farming community. It's nice, but I'm looking forward to the sun and warm weather soon, hopefully.
Oh, great. Well, I'm really looking forward to talking to you today about IBS. And I think it's safe to say that the public is much more aware of IBS today than, say, even a decade ago. Many people are certainly familiar with its symptoms, and the interest in the low FODMAP diet, which we'll get into later on, is certainly growing. I saw a stat just last week that, even the month of January this year, Google searches for the diet have increased over last year. So lots of interest, I would say. But let's start with you. You've had a good 30 years experience as an expert in gut health and nutrition. You're a very well-known dietitian. So tell me about your career. What made you want to specialize in digestive health?
Yeah, I will. So when life gives you lemons, right? You make lemonade. I, at 30 years old, actually developed a strangulated intestine. I was pregnant with my middle son. So I was just 3 months pregnant, and I developed this really unusual colicky pain I had never felt before. So I went into the hospital, and because I was pregnant, they kind of observed me, but I kind of rapidly went downhill after 24 hours, and they determined that I had scar tissue from an ovarian cyst surgery when I was 18, strangulating my small intestine. So I had emergency surgery and lost about 8 feet of my small intestine. And as you can imagine, that's where a lot of food's absorbed in the small bowel. That's where all the digestion absorption occurs primarily. And I had food intolerance and just miserable gas and bloating. And really the doctors just said, go home and eat a steak. And I'm like, oh, I need more information. So it kind of prompted me to really understand what it's like to live with digestive distress and the lack of information out there. And so that really catapulted me into the space of GI nutrition.
I see. Yeah. And you do such a good job of providing information to dietitians who want to work with clients to help them with digestive disorders as well. I was really impressed by what I saw on your website. It's funny. I became a registered dietitian as a means to becoming a gastroenterologist. I was absolutely fascinated by digestive disorders, and obviously I ended up not going down that path. I'm not a gastroenterologist, but gut health is absolutely still one of my favorite areas in dietetics. So let's talk a little bit about irritable bowel syndrome, or IBS, which is really common, affecting 1 in 7 people. Kate, can you explain to people what is IBS exactly?
Yeah, so irritable bowel syndrome is a chronic and it's really often debilitating GI condition. It's very what we call heterogeneous. So you can present with IBS with diarrhea, you can present with constipation, you can present with mixed bowel habits, but always there's abdominal pain present. That's a key piece of the diagnostic criteria for IBS. And the Rome Foundation is really the governing body that determines what the criteria is for IBS. We're on the Rome 4 criteria right now, but Rome 5 is being developed, and we're anticipating that that's going to present with some different criteria for diagnostic measurement for this condition.
And other symptoms like bloating, gas, distension, those are common features of IBS as well, are they not?
Absolutely. So bloating is not part of the diagnostic criteria, which is surprising, but 90% of people with IBS experience bloating. And yes, excess gas and passing a lot of gas and abdominal distension where your belly gets really swollen. Those are common presentations in people with IBS.
Can you tell us what we know about what causes IBS in the first place?
The causes of IBS are not fully understood. We do know that in post-infectious IBS, that is caused by an episode of foodborne illness. So certain microbes that we might eat in food that are tainted or, have pathogenic bacteria that cause foodborne illness can trigger post-infectious IBS in a certain people. Not everyone that gets foodborne illness will go on to get IBS, but that is definitely one cause of a type of IBS. We also know individuals that have had adverse childhood events, such as trauma or sexual assault, are at higher risk for developing this condition. We know that there's some genetics because people that have biological relatives are at increased risk for developing this condition as well. So it's microbiome changes, taking antibiotics, food
Mhm.
intolerances. There's a cluster of different things that really can impact this condition.
And speak to how people with IBS, it's thought that their guts are more sensitive. The nervous system in their guts are more sensitive to certain things.
Yeah, so that in medical terms is called visceral hypersensitivity. And we're really trying to drill down what this is caused by. In some individuals, it appears that the gut and brain are really speaking to each other very loudly. So in a person without IBS, you may have a gas bubble and pass the gas and go on with your day, where an individual with IBS has a gas bubble and it's triggering pain and the brain and gut are just kind of screaming there's a gas bubble and it's really accentuated, right? I often say like the brain and gut have a megaphone to each other. So that can cause that altered gut brain axis is what we call, can
Mhm.
cause that hypersensitivity of the gut. We're also learning, interestingly, that certain people have this, what we call dysbiosis or altered gut microbiome. And in that case, we're learning very interesting science. This is kind of novel from Michigan, where individuals that respond to a low FODMAP diet, and I know we'll talk about that in a minute, when you feed those individuals FODMAPs, it actually creates a dysbiosis, an altered gut microbiome balance. And with that, triggers, I know this is a little chemistry, but it triggers your mast cells, these immune cells in your gut, to release inflammatory chemicals. And mast cells are right next to our nerve endings. And this is a pathway that is also associated with this visceral hypersensitivity. So it's not just, oh, the gut and brain are talking
Right,
elevation,
right.
screaming. There's other pathways that we're learning about that are making the gut more sensitive, that we see in IBS.
Wow, that's fascinating. That's fascinating. Research shows that on average, it takes 4 years for someone to get a definitive diagnosis of IBS. Why do you think, Kate, it takes so long for someone to get diagnosed?
Well, for one, it's an embarrassing condition. No one wants to talk about gas and bloating and diarrhea, even with their physicians. Most, even people with constipation, I think it's like 3 out of 5 individuals have not talked to their doctor about their constipation. It's just embarrassing. So that keeps a lot of people sort of behind closed doors. Further, there's no biomarker for IBS. So it really is a diagnosis of exclusion. So you are presenting with gas and bloating and altered bowel habits. That could be celiac disease. It could be bile acid malabsorption. It could be inflammatory bowel disease. So the physicians have to really go through and figure out and rule out these other conditions that might be more life threatening, and then come around to the IBS diagnosis. So there are, these loopholes. We don't have a biomarker, and people don't really like to talk about their bowel habits.
Yeah, it's true. Even clients here that are coming to get help for their IBS are even embarrassed to discuss their digestive symptoms. Many people are. But I think you make a really important point there. I think it's important to emphasize for people who are experiencing ongoing GI symptoms, it is important to have a doctor rule out other more serious conditions, like you mentioned, celiac disease, inflammatory bowel disease. So it's important that people don't just self-diagnose.
You said it. Amen. Definitely. And, there's so much misinformation on the internet. So don't search Dr. Google, please. Yeah, work with your healthcare provider to get a proper diagnosis.
What are some of the most common misconceptions that you hear about IBS?
That is a great question. A common misconception is that IBS is, because it's not life threatening, it's not life altering. And it is very life altering. In one study, for instance, they did a survey study of IBS patients, and the patients were willing to give up 25% of their remaining life for symptom relief. That's significant. 25%. When I say that, I get like chills, because that really speaks to the debilitating nature of this condition. So I think that is really important. While it's not life threatening, it is significantly life altering. The other thing is that it is not a psychosomatic disease. This isn't all in your head. You're not crazy. You didn't make this up. While the gut and brain are altered in IBS, this is a very complex condition. So I think, those two are like some of my big misconceptions with IBS.
Yeah, yeah. Thank you. So let's get into diet now. There are a number of diet modifications that can help manage IBS, but the low FODMAP diet has been shown in studies to improve IBS symptoms in 75% of people with IBS. The low FODMAP diet's recommended as the first treatment of choice for people with IBS. Kate, can you define what FODMAPs are exactly, and what happens to people with IBS when they consume them?
Excellent question. So FODMAP is an acronym. It stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. In short, these are a group of small chain, very small carbohydrates that are either fibers or sugars that are commonly malabsorbed. Because they're small, they have the capacity to pull water into the gut, and that can make the gut feel bloated and distended. They are also fast food for gut bacteria. Because they're so small, our microbes can get at them quickly and create gas. And that gas can make us also feel bloated and distended and cause some cramping. So that is the overview of the FODMAP term and how they can cause GI symptoms in a nutshell, although we are learning, like I mentioned earlier, It can affect a wide cascade of effects in the gut microbiome and the immune cells
Yeah.
and that sort of thing.
But not everyone reacts to FODMAPs, right?
Correct. So you said up to about 75 to even 80% of people can have positive effects to changing and reducing FODMAPs in their diet. But the literature is a little bit all over the place. And in one of our really big studies in the US, only 50% responded. So you could say up to 50% of people potentially will not respond to the low FODMAP diet. So there is a window. Not everyone will benefit from the diet.
Right. And I think it's also important for people to know that the low FODMAP diet is not a forever diet. It's really a diagnostic approach. So Kate, walk us through how the phases of the low FODMAP diet work and what the end goal is.
Okay, so it's a 3-phase intervention. The end goal here is really to determine if a patient is sensitive to FODMAPs, which FODMAPs they're sensitive to, and to add back any FODMAP containing foods that they're not sensitive to so that they may consume the most liberal diet possible while managing their symptoms. The diet takes a 3-stage approach. The first phase is the elimination phase. This is typically 2 to 6 weeks, and we restrict all high FODMAP foods from the diet. The patient really should see a GI dietitian because it's a very nuanced diet. The foods are really everyday foods that many people consume, and it requires a lot of education from label reading to grocery shopping to meal planning.
Oh, that's what I was going to say earlier. It's not necessarily easy for people to know which foods are high in FODMAPs, is it?
Not at all. Watermelon. People think of watermelon as just having water, so you don't think about it as having all these other little molecules in there that can contribute to GI distress. So yeah, it's not intuitive at all. And a dietitian that's well-versed in this can really make a difference in application.
So the elimination phase you're saying is 2 to 6 weeks.
Correct.
What are the next steps?
The next steps is sort of the reintroduction or phase 2. And this is when we're systematically testing the individual's tolerance to FODMAP, what we call subtypes. So not to get complicated, but a disaccharide that's eliminated, the D in FODMAPs that's eliminated during the diet is lactose. This is a 2-chain sugar. And we would be testing the individual's tolerance to lactose. How much can they tolerate lactose in a small amount? Can they tolerate lactose in a large amount? And get an assessment of where their line in the sand is for tolerance. And then we would move on through other FODMAP subtypes. And that is how we identify their personal triggers. And then onward to phase 3.
Yeah, where you personalize someone's diet based on their tolerances and intolerances to FODMAPs, right?
Exactly. And that's when we want to get all those foods back in so they're eating as liberally as possible.
We have a low FODMAP diet program for IBS at Medcan, and I can tell you that many of our clients who during the elimination phase, they feel markedly better within days of starting the diet. So symptoms that they've been living with for years are gone or dramatically reduced. And I think as a clinician, for me, that's amazing to see. Wow, it is something to do with FODMAPs. Now we can go on and figure out your tolerances so that you can control your own diet at the end of the day and feel good about that. But some clients, because they feel so good, are afraid to go through with the next phase, the testing phase, the reintroduction phase. And there have been some clients that choose to, I'm just going to follow this low FODMAP diet forever kind of thing. What do you say, Kate, to these clients?
Yeah, I really try to educate them from the beginning that there is a reintroduction phase and we're going to go through it. There are those patients that have significant fear or, hey, you feel great. Why would you want to go back to where you felt? I can understand sort of the mindset of that, right? But it's important that they do it because why make your life socially more difficult? You can't dine out. You can't do some things because the diet is so restrictive, right? We don't want to affect their quality of life for the long term. So in those patients with a lot of fear, we just go really slow. And just slowly increment. It might take us longer to get through that phase of reintroduction, but that's okay. As long as they're comfortable, we just move them slowly through. And that really helps them. And if you're a trusted provider, they'll go with it.
Yeah, great. I know that getting enough fiber can be an issue during the low FODMAP diet phase. Since wheat bran, beans, and lentils, certain fruits and vegetables are removed from the diet. What suggestions do you give clients to help them increase their fiber intake?
Yeah, I really focus. It's always been, as a registered dietitian, GI or not, I'm really big into the balance plate, right? So you want to make sure that patients are getting a good number of vegetables, even there's plenty of vegetables that they can eat within the low FODMAP diet. I want them to have at least 2 fruits a day. And, adequate whole grains that are allowed. Just because wheat bran isn't allowed, that doesn't mean that whole oats aren't allowed, or they can have quinoa for extra fiber, or eat the skin of a white potato for extra fiber. I love chia seeds and hemp seeds. So they add those to their morning oats or on a lactose free yogurt. So I think, again, just emphasizing GI dietitians are going to really focus on fiber because we know fiber is important not only for our gut microbes, but to keep us regular. And if they're constipation predominant, it's particularly important.
For people who are considering a low FODMAP diet, what are some tips you can give them for successfully implementing the diet without compromising their nutrient needs?
Do your homework. First, if you can work with a GI dietitian, I think that will be extraordinarily helpful. But also, really understand what foods are allowed in the diet. Focus on what foods you can eat, and then look at the grains, look at the vegetables, look at the fruits, look at healthy fats, and really come up with nice, balanced meals that you're excited about that are not difficult to produce in your kitchen. You don't want to spend 2 hours making dinner. And often when I'm working with patients, we really look at what they normally eat and then try to mimic that as much as possible. They like pasta. Okay, we can find a suitable gluten-free pasta and a lovely, low FODMAP pasta sauce and suitable salad ingredients. So you just work with them so it doesn't feel like they're flipping their diet completely upside down, but just modifying the FODMAPs as best they can.
Yeah. You mentioned gluten-free pasta there, and this is something that I'll often have to talk to clients about because I think there's a perception out there that gluten is a FODMAP. They have to avoid gluten, but I tell people it's just a proxy to avoid the fructans, the FODMAP that are in wheat, rye, and barley. But many people think mistakenly that it's gluten that's bothering them.
Yeah, absolutely. And I think there's a lot of physicians out there that think the low FODMAP diet is gluten free. So that, there's a lot of misinformation. But yeah, to your point, gluten's a protein and FODMAPs are carbohydrates. And we're focusing on reducing those carbohydrates. And right, fructans are the carbohydrate or FODMAPs that are in wheat. So we are going to reduce our gluten when we go on a low FODMAP diet, but just by proxy.
Right, exactly. Do you have a favorite low FODMAP recipe or snack or a hack for clients?
Well, I'm really into the gut microbiome science. So I've been following this since 2000, really. Just love the whole nature of what's going on inside our colon with all these microbes. So I want to feed them. And so I love doing like an energy bite. It's a recipe that I use with my patients a lot. Just a mixture of uncooked rolled oats with some nut butter, maybe a little maple syrup, maybe some dark chocolate chips for some polyphenols, some chia seeds, and just roll them into a little bite that they can keep in their fridge. And it's just a nice little snack in the afternoon or almost like a little dessert. But it has resistant starch and beta glucan, which are have prebiotic effects. Just lots of goodness for their gut, but low FODMAP also.
Yeah, sounds great. Sounds so good.
Yes.
So, Kate, you had mentioned earlier about some emerging research around the effect of FODMAPs on certain gut microbes, leading to inflammation that may affect how people with IBS experience FODMAPs. Is there other emerging research or trends out there in the field of IBS and the low FODMAP diet that you're really excited about that might impact future diet recommendations for IBS?
I think that we're really starting to understand that certain people with IBS have what appears to be like a potentially pathogenic microbiome. And they can see that by looking at different metabolites that microbes make and certain microbes that are present in the gut. And when they look at those particular people and they put them on a low FODMAP diet, that potentially pathogenic microbiome becomes more health-like. When you look at people with IBS that have more health-like microbiomes and you put them on a low FODMAP diet, nothing really changes. And they don't tend to respond to the low FODMAP diet. So I think we're really learning, we're getting into this, little microscopic world and learning that it makes a difference and it is playing a role in who is being affected by adding FODMAPs to the diet. And we're also learning, as I mentioned earlier, that in those people that respond to the low FODMAP diet, when they consume FODMAPs, they're driving this pathogenic microbiome, and that is impacting those mast cells to be activated. It's also leading to colonic permeability, which, allows things to get outside into the bloodstream that really shouldn't be getting out into the bloodstream, different kinds of toxins that the microbes make, et cetera. So it's very interesting, but I think we're probably going to be able to identify by microbiome testing whether Joe should be on the low FODMAP diet or Sally shouldn't based on that. So that is very, very interesting to me.
Yeah, that's what I was going to say. I mean, we're not there yet, but it's, just this whole future of personalized nutrition. And one day a microbiome test will tell us who is going to benefit from this dietary approach and who won't. So you've said that the low FODMAP diet doesn't work for everyone. We know that. And there are other diet strategies to consider instead. Can you see right away from someone, from their symptoms and their diet history, that, oh, no, this isn't about FODMAPs, this is about something else?
When I'm working with patients in a clinical setting, I'm really looking at their primary symptoms and what is going on, and then what they perceive dietary triggers to be in their diet. Sometimes that art and science of looking at some of that data can really help determine, is low FODMAP diet for this patient, or should I just try to switch up their fiber intake? Or it looks to me like they're just consuming too much caffeine and alcohol, and that could be the primary triggers to their diarrhea. Let's do a little gentle diet cleanup rather than doing a whole, elimination diet. The low FODMAP diet has best evidence for reduction in pain and bloating. So it does affect alteration in bowel habits, but really the strongest evidence is for those two symptoms. So if someone's coming in with significant bloating and pain are like their top symptoms, I would consider it, as long as, and this is an emerging area, that they don't have a history of an eating disorder or that they're exhibiting some disordered eating, because we know that people with GI conditions are at higher risk for disordered eating. And so as dietitians and as individuals with GI conditions, we have to be careful about how we navigate diet.
Exactly.
So there are some people that just shouldn't be having the diet. We don't want to trigger an eating disorder.
Exactly. So beyond diet, what other lifestyle changes do you often recommend to clients for managing their IBS symptoms?
So as a dietitian, one of the easiest behavioral strategies that I use is diaphragmatic breathing. So this is a deep breathing technique that engages the parasympathetic nervous system, which is the rest and digest mode. This is a great technique to use after meals to really prep the body to get ready to relax and just digest the food. It's good for urgency, it's good for bloating, and it's something that really any clinician could teach a patient. So it's suitable for a dietitian. If I had a patient that I thought really could benefit from gut brain therapies, I might also consider cognitive behavioral therapy, which has excellent research to support its use in IBS, or gut-directed hypnosis, which is a very specialized hypnosis that can help really calm some of the physical symptoms associated with IBS. But then there's good sleep. Sleep habits are huge. Getting patients to just relax, have good sleep hygiene, get their 7 to 9 hours. Exercise, getting out in nature, forest bathing. All of those things can also help. I always talk to my patients about external cues in their home. Nice music, light a candle, things that go, oh, it's time to relax now.
That's right.
So they can just take it down a notch, because that'll take their gut down a notch too.
Yeah, that's great advice. Kate, is there anything I didn't ask you today that you would have liked me to?
I I think you did a really good job kind of doing an overview, but I think I would just say a couple things to patients out there. Usually it is IBS, and those that are diagnosed with it can feel pretty satisfied that is their diagnosis. But if you've tried a variety of treatments with your treatment team and you feel like every stone has sort of been turned, there are IBS mimickers that should be considered. And those include things like sucrase isomaltase deficiency, which is another type of carbohydrate digestive enzyme deficiency, kind of like lactose intolerance is a digestive enzyme deficiency. We're learning that for people with IBS-D, sucrase isomaltase deficiency may be present in 1 out of 10 of those individuals. That is a very high number.
So IBS-D, you're talking about diarrhea dominant IBS.
That's correct. Yes. So if they are prone to diarrhea, we are learning that in the adult patient population, in individuals, particularly those that don't respond to traditional therapies like a low FODMAP diet or otherwise, they may have sucrase isomaltase deficiency. I think that's extraordinarily new and novel and something else to consider. Of course, we've known celiac disease may be an IBS mimicker, but other things like bile acid diarrhea is another one that's very common in patients with IBS-D. The other thing I would say to people that are out there with constipation predominant, 2 green kiwi fruit. I use it all the time. Excellent evidence to help bulk up stools, soften stools, and eliminate. So that's just an easy thing to add to your dietary repertoire. I freeze them and chop them and freeze them and use them in my smoothies all the time. So I'm a big proponent of that. But also, pelvic floor physical therapy is something that and I find it to be hugely beneficial for my patients with constipation. So it doesn't have to be all diet manipulation. I think that's one thing patients tend to go to first, and that's great. But physical therapy and gut directed hypnosis, there's a lot of tools in your toolbox. So if
Exactly.
diet doesn't work, go for something else.
Yeah, thanks. That's great advice. So many clients that come to us for help with their IBS are taking probiotic supplements, thinking that going to take a probiotic supplement, it's going to help me. How do you feel about probiotic supplements? I'm curious.
Yeah, so I don't typically use them. The main academies of, GI societies here in the US really don't tout them as evidence-based at this point. That being said, it's possible there's some evidence in certain people. Like again, that individual microbiome is so different person to person
That's right.
that we may find some individuals that do benefit from probiotics. But I don't think it's quite as, everyone should take a probiotic. I'm not in that camp.
I am
At
not in that
all.
camp either. Absolutely not. Yeah. Kate, what is the gravity theory? There's a notion out there that gravity may be involved in IBS.
The gravity theory was put together by Brennan Spiegel. He's like this brilliant researcher from Cedars-Sinai, and he's just looking at all of the symptoms that one experiences with IBS and how gravity could play a role. It's very interesting because gravity can impact the way the gut and brain interact. It can change motility. It can change our gut microbiome. He talks about the sort of what he calls the chassis or the body's just core strength and how certain people with, like, for instance, Ehlers-Danlos syndrome or have those connective tissue disorders, they don't have like what he calls a strong chassis. Like it's not held together. So if things aren't held together very well, like Ehlers-Danlos, very common, it's 70% women. People that have hysterectomies, like just prolapsing, the effect of just everything being pulled down. If you look at all these different angles, how that can tie into all the symptoms that are common to IBS. And the people that have these other conditions that often overlap with IBS that impact sort of this, what he calls the chassis or like of a car, like everything kind of holding it together. And so then you're like, well, so what the heck? What do we do with that? So I talked to him at a conference and he said, really what we think is just solid core exercises,
Really?
really getting the core tight So that can be helpful. But it is interesting. And he talks about like how the brain and gut are so highly connected in the sense like if you're on a roller coaster and you have that like, anticipate and how your gut feels it, right? It's sort of like those neurons in your brain and gut are so highly linked. It's anticipating from the G force, that feeling of like we're going down and
It's fascinating.
it is a very fascinating paper. At first I was like, this is crazy. But then when I read it and heard him speak, it was like, this is really novel. He's a maverick. He does virtual reality for IBS, which I did. I used the set. It just came out on Apple. It's ridiculous. Really, really, really cool. I think that's going to be a really novel approach. They've used it in women during childbirth, and it has reduced their perception of pain and what they think, how long they've been in labor. They think it's less than it was. And
Wow.
really, really interesting.
Mm-hmm.
Science is cool.
Yeah,
Can you
it
tell
sure
I like
is.
it?
Yeah. Kate, this has been great.
Oh, good.
I want to congratulate you on your brand new book, Mind Your Gut, the science-based whole body guide to living well with IBS. I have ordered my copy. Tell us a little bit about the book.
Yeah, I'm really excited about this. Well, 90,000 words. We really worked hard. My co-author is a GI psychologist, and for years we've been talking about creating this book to really provide a full toolbox for people with IBS, not just diet, not psychological only, but really to combine a nice comprehensive book for patients and really healthcare providers. And we review all types of behavioral therapies, different concepts about food intolerance, all the details you need for the low FODMAP diet, and when diet's even appropriate or when it's not. We really walk the reader through that. But we also provide symptom-based solutions. So if someone has constipation, we talk about behavioral therapies, lifestyle therapies, supplements with evidence, diets with evidence, and bloating and diarrhea and abdominal pain. So we really button all the symptoms that people feel where they could really go, well, constipation's my primary one. They can look in the book and see what we recommend. And then a huge resource list with low FODMAP brands, foods we recommend, psyllium husk we love,
Of course.
a number of things. So it's pretty comprehensive.
I was just
Very
going to
excited.
say, yeah, I can't wait to read it. Very comprehensive indeed. Well, thank you so much for joining me today and sharing your expertise with us, Kate. I really, really appreciate your time.
Well, thank you. I really appreciate the ability to engage with your audience. So thank you, Leslie.
That was Medcan's Clinical Director of Food and Nutrition, Leslie Beck, in conversation with Kate Scarlata, registered dietitian based in Boston, best-selling New York Times author, whose new book, Mind Your Gut, is out now. If you want to learn more about the low FODMAP diet and whether or not it could be the right fit for you, contact Medcan by emailing nutrition@medcan.com or call 416-350-5900. Follow Leslie Beck on Twitter @LeslieBeckRD, and give Kate Scarlata a follow on Instagram @Kate Scarlata. That's KateCsarlata. She's also on Twitter @KateScarlata_RD. Follow Medcan on Twitter and Instagram, and subscribe to us on YouTube @MedcanLiveWell. We'll post episode highlights and other links that you can visit on our website, eatmovethink.podcast.com. Say hello and send us a tip or a suggestion for another episode by emailing us at info@eatmovethink.podcast.com. Eat Move Think is produced by Ghost Bureau. I'm Jasmine Ratch, managing producer. Social media and strategy support is from Chantel Gerten, Andrew Imix, and Elaine Genet. Executive producer is Christopher Shulgin, and we will be back soon with another episode examining the latest in health and wellness. This podcast episode is intended to provide general information about health and wellness only and is not designed or intended to constitute or be used as a substitute for medical advice, treatment, or diagnosis. You should always talk to your Medcan healthcare provider for individual medical advice, diagnosis, and treatment, including your specific health and wellness needs. This podcast is based on the information available at the time of preparation and is only accurate and current as of that date. Source information and recommendations are subject to change based on scientific evidence as it evolves over time. Medcan is not responsible for future changes or updates to the information and recommendations and assumes no obligation to update based on future developments. Reference to or mention of specific treatments or therapies does not constitute or imply a recommendation or endorsement. The links provided within the associated document are to assist the reader with any specific information highlighted. Any third-party links are not endorsed by Medcan.